Well, good morning and good afternoon from coast to coast. I'm Elizabeth Yu. This is Dr. Nicole Fram, who is, I mean, she looks amazing, and it's like 7 in the morning for her or something like that.
It's just for you, Liz.
um, but we are here today, as you know, on behalf of Johnson & Johnson Vision, and thank you so much to Covalent Careers. We will be actually sharing great information with regards to the experience that both Dr. Fram and myself have had with the innovations in the monofocal space, particularly as it relates to the TECNIS Eyhance IOL, and kind of how it fits into the portfolio of what we're doing with cataract surgery and in the portfolio of cataract surgery for J&J. And it's just been such welcomed advances and innovations that have been taking place. As you know, both Nicole and I are consultants. I'll let you guys see that information. And here's that beautiful girl, Dr. Fram. I'll let her introduce herself right now. I'm kind of telling us about, her actual practice and such.
So my name's Nicole Fram. I'm in practice in Los Angeles, California. I do cataract, complex cataract, refractive cataract surgery, and cornea surgery. And I'm the managing partner at Advanced Vision Care.
And as you guys, as I've already mentioned, my name is Liz. I'm in a multi-specialty practice, Virginia Eye Consultants. So Nicole and I like to say that we're holding down East Coast, West Coast. And this is like the only way I get to see her. So thank you to you guys for giving us this opportunity. I haven't been able to see her since pretty much Academy, which feels like forever ago when I'm used to seeing her a lot, particularly with our podcast. Whoop, whoop. Okay, so let's talk about today's agenda, and it's going to be quite a full one, and it's one that both of us are so passionate about because we've had so much more experience over the last year with regards to the J&J portfolio technologies with the monofocals and all the other offerings. So we're going to start with an Eyhance overview, specifically what the optic actually is, how it differs, how it's unique, where it fits in, patient outcomes, and where we utilize it clinically. And then the selection process is so important as to, how do we utilize the benefits of the Eyhance in a nuanced way so we can help our patients, give them the most in terms of optimizing benefits, minimizing side effects, and with those comorbidities that exist with our patients. We have 3 different case studies, and of course, we will do our very best, which means I need to chat less, so that we can leave a good amount of time for question and answers. So with that, I will like to turn this over to Dr. Fram.
So the question is, what makes the TECNIS Eyhance so special? And really, it's the first monofocal lens that's been designed to slightly extend the depth of focus, and that's been measured with bench testing. When we think about an IOL, monofocal IOL in the past, it was just, let's do the best we can for distance, but then the patient can't see their dashboard or their food. And so a lot of patients think that's what you want. I want to be 20/15 in the distance, but if you can't see your intermediate world, where does that leave people? The other thing we want from a monofocal with a slightly extended depth of focus is we need the image quality to be comparable to the monofocals that we've been using in the past. And what we find with the TECNIS is that there is superior nighttime image contrast performance, that we're not getting any different of a dysphotopsia profile, which we'll talk about later, compared to the other TECNIS platform, monofocal, the ZC-BOO. And its preloaded delivery system is incredible. We're going to show you how to use that efficiently later. So this is really just taking us to the next level. And it's really interesting when you kind of get marketing material and it says one thing and then it performs. So this high quality vision starts with the strength of the TECNIS IOL platform in general. And what's happening with this lens is it's correcting spherical aberration to essentially 0 in the center. And it's using this wavefront designated optic. And then it provides this sharp vision quality. There's low induction of chromatic aberration, as it is with all TECNIS materials, which provides this really high contrast performance under all lighting conditions. And we observe less capsule phimosis, which minimizes potentially any sort of decentration that can happen over time from asymmetric fibrosis of the capsule. And this gives us this high quality vision that we want to last someone for their entire life. So we also note that with this TECNIS platform that there's not a lot of glistenings associated with this lens, and whether or not that actually causes issues, we will know in the future. But this is a video from Eric Donenfeld. And in this video, what you're going to see is the Veritas system and how efficiently it's used. So I had the privilege of being on the advisory boards as they were improving the Signature Pro. And the one thing that you look for when you're using a phaco platform is you want to make sure that it's efficient and that chamber is solid the whole time. You don't want the capsule bag coming up into your phaco tip. Now here he used the Catalyst COS platform, which is the femtosecond assisted laser, and it's pre-chopped, it's pre-segmented. And you can see that there's an extremely efficient way once he starts getting the pieces where he just stays in the center, and through the fluidics, the entire time, the pieces are just coming to him. But more importantly, as you'll see with the video as we move forward, that these actual pieces are coming to him without the capsule coming forward at all. Think in some platforms, you could see the capsule bouncing, and it really, on that last piece, it really creates a lot of anxiety. The other thing they did with this platform is the handpiece is customized. The cords come out in a beautiful way. The foot pedal is customized for small feet, like some people, and larger feet to make it comfortable so that you don't have problems while you're phacoing. And it's just really one of those advancements in industry kind of listening to what we were having trouble with and making sure that we have that advanced fluidics. There's also a gas pump, and that's the reason why the chamber is staying solid, in addition to changing the compliance of the tubing. So those two things make this system different. Then, you take the cortex out just like any other case. And then what you're going to see in just a moment is this inserter of the Eyhance technology, which is the Simplicity. And this is probably one of the favorite things that's entered our OR in the last year. And the reason why is because the techs are just so excited that there are reproducible way of delivering an IOL. There are some nuances that we're going to talk about later in terms of how to preload it with BSS versus OVD. But you see the whole process the entire time. The chamber's solid, putting the lens in. I do the same thing that Dr. Donenfeld does. I want to be past the lip of the incision so that I don't cause any Decimase detachments. And that may require a little bit of a larger incision. And then this lens comes out just beautifully, rotating into position, and the case finishes up really nicely. So this is an example of using the Eyhance and also the new Veritas system, which, like I said, has efficiency and has this anterior chamber depth stability that differentiates it from past platforms.
So I could not agree more. I mean, we recognize that there are different dual pump systems that are out there. With the Veritas, I'm not gonna lie to you. I mean, I use the Centurion. That's where my experience is at, which is a peristaltic fluidics. And with that system, it requires full occlusion in order to build vacuum. But once you're used to that, that's the technology you use too. And the Centurion has great anterior chamber stability. So it utilizes a different fluidic platform. The Signature, I just didn't feel as comfortable with the Signature, even the Signature Pro. But then when I trialed the Veritas, the first thing I said was, let me just compare peristaltic to peristaltic so that I can give you a really fair comparison, because for someone who's switching over from Centurion, they're going to need to know. And I'm going to tell you, there was essentially no difference, and that shocked me. So there was no delay. Maybe my surgery was 30 seconds longer than my first surgery, the case right before, which was on the Centurion platform. And as I started using the Veritas more, that's when I started mixing and matching the way I wanted to have the fluidics work for me. And for myself, I found that essentially, like, for example, for cortical removal, I wanted Venturi. Right.
Hey, you want it to go fast.
Yeah. and it comes right to you. You can stay in the center, right?
Mm.
And especially because like when we do a lot of those femto cases and there's the truncation of the cortex, so you don't have the fimbriated layer, with the peristaltic system, you have to like go and engage peripherally in order to draw the cortex to you. And at the end, I have never seen viscoelastic come out from behind the lens as quickly and as stably as I've ever seen with the Venturi pump utilizing the Veritas. So ultimately, at the end of the day, after case 16 of Veritas, I was actually quicker on the Veritas platform on my first day trial than I am on my Centurion, because I could utilize a hybrid form of in which step did I want to use which pump. Did you feel the same way, Nicole?
Yeah, when we were trialing it, I think, and then this was in the demos, it's really incredible how I was always afraid of a Venturi system. I felt like it was too fast, so I'm a very like slow and methodical. I keep everything in the center. I bring all the pieces towards me, much like Dr. Donenfeld. And so to be able to actually feel safe with that chamber stability, that was what I was looking for. And the fact that I'm always judging a phaco by that last piece. Right? When you're taking that last piece, I want to see everything solid because I do a ton of zonulopathy cases, pseudoexfoliation. So that was what I was most impressed by, because it really answered the question that needed to be, or the problem that needed to be solved.
And that's absolutely right. So between the lack of seeing post-occlusive surge, which is obviously from a safety perspective going to be so important, especially with dense nuclei, and then number two, those subtle findings that you're looking for. I want to make sure my iris isn't billowing at all, because that shows you that there is a little bit of stability or instability of the chamber, which then leads to your pupil coming down as the case progresses. None of that happens. And I just didn't expect to see that. So I'm going to say that the Veritas is a huge leap from Signature Pro. Maybe not everyone would say that, but in my own experience, for someone who is coming from being a peristaltic fluidic surgeon and then trialing out Stellaris, Signature Pro, Veritas is a huge leap. And I feel that for anyone who uses either Infinity or Centurion, you could easily feel very comfortable starting with the peristaltic pump function with the Veritas. So, I think that is a very, very nice and exciting offering in addition, because this allows surgeons to really customize how they want to operate and how they can, even increase efficiencies. The machines already do it for us with their improvements and their subtle advancements, but now we can utilize it to our advantages within the different steps. So Nicole, when I'm looking at this information, where would you consider choosing an Eyhance lens over other monofocal lenses? Like, what makes this different?
Yeah, it's such a good question because we have so many IOLs to choose from, right? So the big question you want to ask is, what were you doing before? Before, if a patient wanted distance, I would do distance in a -50 in the non-dominant eyes, that I would give them the dashboard, or so minus 0.50 diopters. I give them the dashboard, I give them their food, because I don't want to lock them into just distance. And what I'm finding is that I don't have to do that anymore. All I have to do is put Eyhance in and do it for distance. And I'm able to get patients to have this slightly extended depth of focus. I don't tell them that they're going to read, but I tell them that they're going to not be locked into just distance and have to put reading glasses on to see their food. And this is what we've been waiting for. We've been waiting for something that allows us to give them the best distance possible while giving them their slight intermediate world, so that they don't feel that, the troubles of presbyopia, slammed upon them right away. So what makes it different is it's allowing me to make patients happier and happier. And there's no difference, in my opinion, from the TECNIS platform for the ZC Boo.
Love it. I could not agree more. Whereas before, especially with women or shorter patients, I really, made certain that as we talked about distance from myopic patients, particularly who are like, they really desire distance. You don't realize how much of the far intermediate world, specifically cooking and making food and seeing yourself in the mirror, what losing that was because you
Right.
don't expect to lose that. Now I don't have to have that conversation because that's a given, even if they're Plano or even a plus a quarter, which we don't, we're hoping for Plano exactly. But if they end up on either side of it, they're still gaining that far intermediate
Mhm.
from a clinical perspective, which I think is just absolutely, a
So
fantastic
this
thing.
question should be, why do you not choose an eye hands? That's the question.
You're right. Like in terms of quality of vision, unbelievable. I mean, would you say that in the manipulation with the added negative spherical aberration with this modified enhanced IOL, have you had any patient in any eye thus far that has complained of contrast sensitivity issues?
No, but I don't know if that's necessarily something that they, will say to me.
Hmm.
But of course, you want to give a lens that's going to give the best contrast sensitivity and do the best in low light and dark and light conditions. So for me, I don't get a sense that someone's going to come in and say, I feel like my contrast is low, unless we're using some of the old school multifocals.
Gotcha. Right. So let's talk a little bit about the actual optic itself. As you can tell, Eyhance versus ZC Boo, which is the TECNIS one-piece IOL. I'm not going to tell you which one's what because you can't tell the difference, and that's exactly true. It's a refractive technology through and through. There's no diffractive component or rings to it. It's the same exact material in terms of the chromatic dispersion and the excellent low Abbey number with the tight chromatic aberration correction and profile, and the spherical aberration, where there is in the periphery that net neutral, which is what you want to be able to do because of the annular positive spherical aberration that occurs in a dilated pupil. So in mesopic conditions, still has that beautiful ability to help patients to have that better mesopic contrast sensitivity. What is different is the higher negative spherical aberration that occurs in the center. Now, it is extremely gentle. What it amounts to is about an extra zero point 0.4 to 0.45 diopters of added spherical aberration, and which is add essentially. So having this bump, which is a positive bump, so giving the quality of an extended focal point from an optical standpoint. This is not an EDOF lens, but because of the manipulation with the spherical aberration, it does, when you look at the rays of light, create an extended focal point. So for patients, this is exactly why Nicole and I can say that I know that my patients will gain an extra quarter to a half diopter, somewhere in there, of that range of vision beyond just distance. Would you agree with that, Nicole?
Absolutely. This is the part where until you start using it, you don't believe it, right? So you're like, okay, yeah, there's another lens on the market. But this is really a true statement. But as opposed to other technologies that have put a bump on the center, and it caused a lot of issues with halos and glare, this is not a true bump. It's a change in the spherical aberration. And that zero point 0.4 change is just enough to not give you issues with image quality, but give you just that depth of focus or slightly extended depth of focus that you need. So I fully agree.
So this is not your Crystallens HD, if you guys recall, where there was a very obvious visible hump in the center where of negative spherical aberration. This is totally different from that. And it is imperceptible when you are looking at it and checking the reflections intraoperatively against the red reflex, you can't see that difference. But what it translates to clinically is that I can trust that there are things that I can do now. So for example, if I were to leave a patient a minus 150, I know that they're going to get closer to a minus 150 up to maybe a minus 2. So for a tall patient, I know that they're going to have great minus 150, which defocuses to that 60 centimeter range for reading or 66 centimeter range for intermediate reading, as well as through almost maybe 50 centimeters because of that extra reading. So that allows me to then change what I do as it relates to pseudophakic monovision or how I aim the patient per se. And this is beautiful to see, like, for example, this defocus curve. And Nicole and I have talked about how this happens all the time, where I have a patient who wants to remain nearsighted. They're about a minus 150, even, plus or minus a quarter there, but their distance vision is unreal. It's like
Right.
20,
So this is where it's off the charts, because you aim someone to minus 150, you expect them to have like 20/50, 20, maybe 20/40 if you're lucky, depending on the spherical aberration of the lens, uncorrected, and for distance. And these people are coming in, I'm aiming minus 150, and they're seeing 20, 25, 20, 30 in the distance. Now, that's not everyone, because it depends on the pupil size, but this is just a game changer, because now when you tell someone, I'm going to aim you near because you were used to taking your glasses off to read the computer and read out, 60 centimeters, they're not as compromised walking around the world, right?
Yes.
I mean, and that's really what you want. You want someone you don't want to choose a target and have them locked into that target when you're deciding what's best for them. And it's in those mixed astigmatism patients that we'll talk about later that this becomes really important.
And let's just quickly, further dovetail that with, when we look at this defocus curve, it's comparing the Eyhance to the monofocal. And from the monofocal, it provides about 0.4 to 0.45 diopters of greater defocus. Okay. Now, what about our EDOF lenses, first generation, second generation? If you look at the Symphony provides a lot more. It provides over 0.9 diopters over the monofocal, which is why it provides that great intermediate, right? If you look at the Vivity provides, compared to its monofocal, about 0.5 to 0.55. It's about 0.53 diopters more. So just so you know, kind of perspective of what the actual different defocus curves are as compared to its monofocal, there's an added 0.43 with the Eyhance, 0.52 to 0.55 with the actual Vivity, and about 0.92 with the Symphony IOLs. So that gives you the idea of, and that might clinically translate to what you are experiencing when you're looking at patients' ultimate results postoperatively as it relates to their uncorrected intermediate, uncorrected near vision.
Right. So I think it's really important, though, to not, we still counsel these patients that this is a distance lens, right? And whatever you get after that is kind of a nice surprise. You don't want to tell them that they're going to get distance and intermediate for sure.
Right. And that's actually a great question. I want to ask you, I don't counsel my patients any differently when I talk about Eyhance. I mean, this is in the monofocal class as it relates for me. It for me allows me to, on my strategic surgical planning side, helps me with kind of goals and what I'm targeting and what I'm thinking about based on the patient's needs, especially if we're looking at monofocals. But this is my go-to for all monofocal toric IOLs. How about you?
Yeah, absolutely. And, the question is, it is a more expensive lens. So what do you do? Well, we just raised all of our pricing across the board for any sort of femto LRI or toric LRI, toric marking with LRI system. So you can't just charge more because they're getting an Eyhance, because this is not designated as a presbyopia correcting IOL. But what you can do is say, this is to your surgery center, whatever, this is my preferred lens. And then just, if you're doing a lot of femto LRI, you just raise all your pricing, to account for the differential. And that's been great in our surgery center.
Yeah. And I think that's how we have to do it. Otherwise, it really is going to be too confusing.
Right.
It's already confusing as it is, but then to try to explain or differentiate the nuances and create an additional package, the patient's just going to throw their hands up you're going to either lose that opportunity to help that patient, or they're just going to go with basic surgery. It gets
Right.
very confusing. So I agree with you completely. And I know that Nicole loves this preloaded system. I would dare say that this is the preloaded system that is now the standard of care. It's the gold standard for an actual turn injector kind of system. I love that I can use BSS for it. This is the system that both the Eyhance as well as the Synergy and the Toric technologies come in. And it's wonderful in this day and age, because especially on the side of, we are getting more scrub techs that we are having to train, where there's turnover, and to have preloaded systems where we don't have to worry about them manually loading, which takes time. This is more resistant to scratching even as a product, but still having it preloaded, all the benefits are there.
Absolutely. It's just so interesting how you're in practice for whatever 15 years and you're like, okay, I have my ways. And then something pops into your world and you're like, it's such a simple thing, but everybody loves it. And so they're like, why won't all the companies do this? And it really is the gold standard. I love how you said that now for preloaded systems. The key is to use the BSS first. Don't preload it or don't prep it too early. And let it sit there, because sometimes the haptics will stick together a little bit. The BSS will help that process. But even so, it's really changed the efficiency in our OR.
Yeah. So, all these different preloaded systems, they can have like a unique thing about it. Like either, some of them in the past, the front haptic came out all, tiddly linked and such. So this one, sometimes it was that the two arms or the haptics would kiss. Now, if you use BSS and you don't wait too long, or you don't load it too early, and then once you actually load it with the BSS, you stick it in a little, vat of BSS too, and swirl it around so that it gets into all the crevices, the two little haptics don't kiss.
They won't stick.
I'm telling you, and it does with OVD for us more. BSS is key,
We
which is great.
We use a hybrid of BSS and a little OVD, but I think those points about putting it in the vat is great. So Liz, in terms of visual outcomes, what's your experience been with Eyhance? We've talked about it thus far, but let's take us through some case examples of how you've used this in your practice.
I'm going to say, obviously with anything, you start off with your healthiest eyes, and then you start saying, okay, well, let me use it in eyes that I know that I can't do, a lens within a presbyopia light splitting type of IOL, but I want to do it with toricity correction. Let's just start there. So the fact that the Eyhance is based on the TECNIS Toric 2 platform, beautiful. I have not had a single rotation or a surprise outcome in terms of residual refractive astigmatism because of a malrotation issue at all. I utilize it in basically in any eye that can get a monofocal, can get an Eyhance. Now, the only word of caution that I would have is somebody who has a lot of naturally occurring corneal negative spherical aberration. So that real protruding cornea, whether it's ectasia with keratoconus, or if they've had really, really high hyperopic astigmatism correction and their K values are 49 or 50 or something, that's where I haven't utilized the Eyhance as much. I kind of go with a zero sphericity lens in those scenarios. How about you, Nicole?
Fully agree. I think that, we don't know yet, right? We haven't tried it. But I would, try to stay away from people that already have that in their cornea to begin with to enhance their depth of focus. So when you see a hyperopic LASIK platform, or exactly like you mentioned, you may want to just go with a zero spherical aberration IOL. I don't go with a positive spherical aberration IOL. I don't find that the image quality is good enough.
Right. No, I am right there with you. And I feel like the actual optics have improved since, the availability of those lenses. But there is something about having that extra negative spherical aberration in the center that just, I don't know how it's doing it. And I need to do some bench research at this, but there is a true increased quality of contrast and it doesn't make sense to me. But patients,
Mhm.
there is a wow factor, and I've used this lens a lot now. I mean, there is a wow factor that I see more often than I've seen in the past. So it definitely doesn't take away. Would you agree there?
Absolutely.
Yeah. So,
Yeah.
and what about the dysphotopsias now? You know?
So, the way you counsel people about dysphotopsia in general is that every lens is plastic. And every lens that we have right now has a square edge. Some have a little rounded anteriorly and square posteriorly, but they all have the potential for causing internal reflections, which is positive dysphotopsia, or negative dysphotopsia, where some of the light rays miss and some of the light rays hit the nasal retina and create a shadow. So you have to counsel patients in general. I'm putting this lens in, it's going to be great, but just understand every lens gives a little bit of glare and halo. But I don't go any further than that with the Eyhance. And I don't feel that extra quote bump that we talked about in the center that's giving us the slightly extended depth of focus is causing any increased halos, areas where you're having problems with glare, starbursts, or anything like that. So if they're going to get a positive dysphotopsia, they're going to get it whether it was an Eyhance, in my opinion, or a ZC Boo. So I just, basically mention it briefly, particularly in patients that have nighttime symptoms to begin with. I make sure I say to them, every lens gives a little bit of glare and halo, but it's usually very well tolerated.
So I have a question for you. So let's say we have a patient with macular disease, maybe a
Yeah.
little bit of NPDR or a little bit of drusen, early ARMD, ERM, someone that you know that you would hesitate to putting in kind of a presbyopia correcting lens. Like for those patients, I'm not going to do an EDOF or, and definitely not
Right.
a multifocal lens. That's just not what I would do, right? But I want to correct their astigmatism using a toric IOL. My go-to, I have zero reservations about using an Eyhance toric there. Do you, or have you seen any issues?
I fully agree now because we have so much experience with it, right? So in the beginning, we both said like, okay, a little drusen's okay, but we want a perfect foveal contour. Well, guess what? Now I've done cases where they don't have a perfect foveal contour and they're doing great. So for me, I mean, they're doing great as well as they can be expected to do well with the lack of foveal contour. I do not see a difference.
Right.
So I think whoever I'm going to put a monofocal in, I feel fully comfortable putting an Eyhance.
And I think that right there is that patient profile. Anyone who you would feel comfortable putting in that monofocal IOL, minus those with a really protruding cornea, that's the patient that could get an Eyhance IOL without having any difference in quality or contrast. And in fact, like I said, you and I have just seen that patients really do have this excellent overall quality of vision. The best part of this is that it does go down to a 5 diopter all the way up through 34 diopters. And for toricity correction, the toric IOL powers essentially mean that we can correct, 1 diopter up to 4 diopters of corneal astigmatism. Do you have anything to add with regard to strategy?
No, I think that, we really are entering a new frontier in terms of our expectations of monofocal IOLs.
Nicole, what do you do? And I've already asked you this, but do you educate patients any differently?
No, I mean, I definitely feel more comfortable that I'm going to deliver on what I'm saying and give them an added benefit. But I just educate them the same way I would do monofocals at this time. But we have to figure out with this lens is, does distance and minus 50 in the other eye give you the same as avidity? These are the things that we need to look at in the future. But we don't say, you're going to get distance and intermediate and just wear reading glasses if I'm aiming distance in both eyes, right? So we're not there yet, but I definitely just do the same education that I would for a monofocal.
And that actually brings me to another question. Like, how do you routinely aim your patients when you're using your TECNIS Eyhance lenses?
So you have to look at what they're wearing in their glasses. So when I walk in the room, I say to the patient, how do you feel about your vision? Because just because you see a cataract doesn't mean that you run around Los Angeles taking out everybody's cataracts. So that's the first thing. The second thing I say to the patient is, what do you do all day? So are you on your computer? Are you reading right before bed like this with your iPhone? What are you doing? And really, I want to know what they can do with and without glasses. And I spend most of my time figuring this out. And then after that, I customize to that patient. I don't tell them every IOL that's out there. I say, do you drive a lot at night? What is the profile at night, problems that you're having? So I go through all of this and then I decide on what IOL to use. And then if they say that they can see their distance in computer without glasses, then I offset the Eyhance in the non-dominant eye to about a -75, and I do distance for the other eye. If they say I really value distance, I just do distance both eyes and I get a surprise.
I love that you do that. I mean, I think what's in their glasses is so important to how I'm going to target their eyes. I mean, because if I've got a patient who started like a +2 in both eyes, I mean, I'm going to aim them plano. You know what I mean? Because if they end up plano to maybe a +1/4, they're going to be thrilled because their world, I mean, it's beyond the 20 feet realm of what they used to have as clarity of vision, and they never had this range.
Right.
But if you target plano to a -2 myope without really going through that conversation with them, game over. But the beauty is, like, I do the same thing. Like, I can aim between a -1/4 to -50 or -50 to -75. In those who started off myopic, they get more minus, in terms of clinical uncorrected vision, but their distance is not as affected. So they can still stay in that 20-25 range in that non-dominant eye, and then aim great for plano in the dominant eye if they're looking for the distance vision. And I may say, you're going to notice that your dominant distance eye is a little bit clearer than your other. If you check, put both eyes open, you're not going to notice.
Don't do this.
Right. So this is the first clinical case. We're going to try to get through one or two of them. 61-year-old female. She can no longer recognize her students' faces. She's a high school teacher. Now, she has been successful until more recently with soft contact lenses, monovision goals. Right eye is plano, left eye -150 goal. Average height. And she desires sharp distance. And as you can see here, she's got kind of a unique refraction, and that left side might just be more of a myopic shift, but there you have it. So her right eye is her dominant eye. She doesn't have a whole lot of sill, but you can tell overall relatively clean with the rule of astigmatism. This is the only thing that I do notice. Fortunately, the ERM and the blunted foveal reflex is in the non-dominant eye, or the eye that was also aimed for near. It would be a different scenario if it was the reverse, So it's the left eye that has this ugly OCT macula. So what are the options that you would consider for this patient, managing astigmatism and also targeting for your patient here?
Right. So I think initially when I was trying the Eyhance, I would have said, in the better seeing eye, put the Eyhance, and in the other eye, put a ZC Boo or a toric correction with the TECNIS 2 platform, which is incredible. And we'll get into that. But now with more and more experience with this lens, I would do Eyhance in both eyes without any reservation. But the patient still has to be counseled that the eye with the epiretinal membrane and the thickening may have decreased visual acuity and will be different from the other eye. So you still have to go through your same counseling. It's not going to magically make that ERM go away. And then the other part of the counseling with patients with ERM that are pre-existing, if you see intraretinal cysts, you want to continue and maybe even pre-treat with an NSAID for longer than the 4 weeks that we normally do, and have it extend to maybe 8 weeks, because those patients are high risk for CME postoperatively. And if you tell the patient this before the surgery, then it's their problem. If you tell them this after the surgery, then it's your problem.
Absolutely. And also, the one thing here is, whereas before we have preached over and over again that phakic monovision is not pseudophakic monovision, right? So minus 150 in a contact or that goal, they still have like about a 50 of reserve, even at the age of 60, right? But if you were to just go with a straight monofocal for a minus 150 goal, patients are ticked because they can't see anything past the computer.
Mhm.
Now, it's different because now with my Eyhance monofocal, it gives me the ability in my 60 and older patients that my phakic monovision much more will simulate what my pseudophakic outcomes will be like, because minus 150 goal in that left eye, they're going to get a little boost there. So it's an easier conversation. It's one that is almost negligible now, whereas before I would have had to say, listen, it's not going to be the same. You're going to need reading glasses more, et cetera, et cetera. It's just not as much of an issue. But I absolutely agree. We just have to be cognizant. But certainly I would do eye hands, fix the astigmatism and aim plano and minus 150 and move forward.
Mhm.
And the patient did do very, very well. So Nicole, talk to us about the TECNIS Toric 2.
Right. So this is another example where industry responded to the issues. We all knew that with some platforms of the toric IOL that it was rotating more readily, and this has been published than maybe some other platforms. And what happened was that they left the toric haptics, or the haptics in general, unfrosted. And so by doing so, it creates this friction. And right now, this is really an incredible advancement, and I have no issues. So if there is a lens that, quote, rotated the next day or the next week, that's because we put it in the wrong position. I can see it on the table that I have to be careful when I'm actually rotating it into position because it's so tacky with the bag. So when we're planning an Eyhance, and any toric IOL, you want to make sure you look at your preoperative measurements. We're going to go through a case where we determine how to, align the axis and identify which patients have regular astigmatism, look for dry eye, Salzmann's nodules, and things like that, EBMD, epithelial basement membrane dystrophy, that have to be addressed ahead of time. So let's go into this case of a patient that I had. He's 76 years old. He has cataracts and he wants it all. So he's a standard patient in our practice. He's referred by his concierge doctor, so he's super fancy. I operated on his wife. I put in Symphony. She's totally happy, doesn't even care about any nighttime symptoms at all. He plays golf every day and wants it all. He wants to see distance. He wants to putt. He thinks I'm putting a telescope in his eye. Easy, right, Liz? So this is a real easy patient. So let's look at his exam. So he is one of these patients that's tricky. He has this mixed astigmatism, right? So he can do a lot. And I had to have a long conversation with him about it. I do document on every patient whether they have pseudoexfoliation, their pupil size, whether they have Goutte, EBMD. We look at the next slide. I think it is standard of care to make sure that you're looking at what they're wearing in their glasses, not your current refraction, but what have they been walking around in their glasses. This helps you look at their Ks and what their wonderful optometrists had done for them in the past to know what their actual cylinder is of the corneal plane, despite as the lens started to develop a cataract. And then standard of care also is to look at the MAC OCT. So we'll go to the next slide. And what you'll see is that he has drusen, but he has a good foveal contour. Now, in the past, I'd be like, this is not a candidate for anyone who I'm going to talk about any slightly extended depth of focus. I'd be stuck with just distance. He would not be able to putt, anything like that. But my ears went up and I was like, okay, let's do an Eyhance on this patient. So there's small to medium drusen. We look at our topography. There's consistent against the rule of astigmatism that was consistent with what he was wearing with glasses. We look at our biometry, which we'll see in a moment. And we look and we see that this is against the rule, consistent with what he's wearing with glasses. So we want to see 3 measurements. This is a IOL Master 700 and a lens star and a topography. We also have tomography. So we have consistency all around with against the rule of astigmatism. And let's go to the next slide. What would you do, Liz?
I mean, This is a patient where even looking at this, I know that they need TECNIS torque too, of some form. I would go with an Eyhance. And I always go to some form of an online calculator where the posterior corneal astigmatism is going to be accounted for. The J&J calculator, you have to click to get the posterior corneal astigmatism accounted for, but that is going to be the best way for us to fix their overall refractive astigmatism, and this patient should do great.
So he's expecting, distance and being able to see the intermediate. So we wanted to go, this is the Veritas System, so I'm not using paper anymore. I'm able to use integrated Ks, so I use all the Ks and then I find the right axis. And from that, we're able to plan our surgery. And let's go through the surgery real quickly. So this patient, we mark just like any other case, because sometimes our intraoperative aberrometry, our marks are not entirely visible. This is using the Catalyst system, and we can fast forward through even all the way to the end, where we'll see that once we put this lens in, as I'm hydrating the incision, I go underneath to make sure that I get all the viscoelastic out. I kind of tap the IOL down posteriorly. And when I put in just that little bit of VSS at the end, I can see whether the lens wiggles, and it just doesn't move at all. You test all your incisions because you want to make sure there's no excessive hypotony at the end of the case. You want it like normotensive. And this is just a beautiful example of how this TECNIS platform just stays right in position. And the patient, I aimed him distance and -50, and we'll look at the outcomes. He was 20/25 in his worst macular degeneration eye in 2020. He came out plano in both eyes, but he's J2 and J3, ecstatic, can see everything. He wanted to know why he couldn't see 300 feet away. And I told him I didn't put a telescope in, but he was definitely pleased with his outcomes. So this is just like the perfect patient where I wouldn't have been able to do anything to slightly extend his depth of focus besides offsetting him with real mini monovision.
And just to set expectations in our last few minutes here, like this uncorrected vision is unreal. J2, J3, that's not the normal. Number one, it helps that the gentleman is taller, right? But some people just have a pseudo accommodation that's part of their cornea and their pupil size that, in addition to having just that little bit of minus, gives them a huge boost from the pseudo accommodation of the Eyhance optic itself and that design. Now, what do you see, Nicole? I mean, is the average, like I would say that patients routinely do get at least J5.
Yeah,
but some get these results.
If you look at the JCRS paper that was published, and you see it was one line, right? So in your mind, I think of it that way. I think of it as one line. You don't want to think of this like a real extended depth of focus lens, right? Because it's not. But it's just a bonus. It's a bonus, and it's great.
Absolutely. So let's just jump. And unfortunately, the only thing that in case 3 will be missing is the fact that we were going to talk a little bit about dry eye management, but luckily we've got eyes on 2022 for so much of that. So let's go right to conclusions. I mean, Nicole, give us some of your pearls on, what you have learned through your journey with the TECNIS Eyhance and, Veritas and the portfolio.
Yeah, so I just think that there's been just incredible advancements in terms of how we've reset the baseline of what we're using with IOL and phaco technology and femto technology. And so really want to applaud industry for really helping us get better outcomes with our patients and answering a lot of the unmet needs. So the Eyhance, image quality, you don't have to worry about. You're going to be able to tell your patients they'll see well in low light, in high contrast situations as well. We can use this and titrate this to what the patient's doing all day without having to offset the eyes. That's something that you have to really appreciate about the Eyhance technology. So if I want to just give them a little boost, I give them micro monovision, right? Plano -50. If I want to give them real monovision, I don't go past -150 for the non-dominant eye. These are things that we were never able to do before. And when they have their distance correction, even with one eye offset, they're still able to function without glasses, mainly during the day. Sometimes they need at night when they're driving. And this has taken us to the next level of performance in patients with epiretinal membranes, POAG, and you don't want to decrease contrast sensitivity, dry eye that's recalcitrant that we need to deal with later after we've put the lens in. They just tolerate things better. And this is a great option for these patients that have these slight imperfections.
Beautifully stated. That was kind of a symphony in of itself. I'm truly, no pun intended, but it's truly one of the most honest, credible. She'll tell it to you exactly like it is, and to hear, what her experience has been like, and truly, my experience has been exactly the same. I mean, and we just thank J&J. Thank you, Covalent Careers, and for allowing us to participate in this incredible symposium that has brought together so many ODs and MDs and giving us this opportunity to learn, to help each other, and to really help our patients. So thank you so much to everybody. You guys, happy holidays. And I can't wait to see you guys all again in the future, hopefully soon.
Thank you, everybody.